Another talk by Dr. McLornan. His talk is going to be Transplant for Myelofibrosis, how to make the optimal decision.
Thank you so much. So the topic of this talk is optimal timing of transplantation. We know it still remains, even in the contemporary era, of new exciting targets such as CALR bispecifics, and I'll talk about our center where we're going to set up a phase 1 trial for CALR-directed CAR T cells, but I think we need to be cognizant that despite all of these exciting approaches, transplantation is still the only curative option, and the focus is really going to be on optimization of timing. These are my disclosures as earlier. So I think timing still in 2025 for transplantation is still controversial for some groups. I think there's still a question mark over those with intermediate risk 1 disease, particularly if you only have a mismatched related donor or a 9 out of 10. I think we're moving obviously towards molecularly annotated scores, but actually we're applying that to the transplant decision. Is that the right thing to do? And there are still many, many gray areas in the whole transplant question with myelofibrosis. We're much better at integrating ruxolitinib into the pre, peri, and post-transplant phase, but as I'll talk about, we need much more data about other JAK inhibitors and other novel agents, and despite improvements globally in outcomes, 1 in 4 to 1 in 5 of our patients will still relapse. I think if we look at the pre-transplant part, we've had ruxolitinib now, at least in the EU, for the last 13 years commercially available, and prior to that, the COMFORT-1 and COMFORT-2 studies. We now have 3 commercially available JAK inhibitors in the UK, ruxolitinib, fedratinib, momelotinib, and pacritinib is only available for us in the Pacifica trial. But if you think about comparisons between the JAK inhibitors, we clearly have SIMPLIFY-1, so momelotinib versus ruxolitinib, and a subset of PERSIST-2, which is ruxolitinib versus pacritinib, where we have no data on rux versus fedratinib versus momelotinib, etc. And that data is lacking as regards the pre-transplant part. We have a lot of trials looking at both single agents and combinations with other exciting drugs, such as PIM1 kinase inhibitors, BET inhibitors, BCL2 inhibitors, but that's kind of fallen off favor. And if you look at each of these individual drug classes, they can all affect the peri-transplant pathway. They can affect immune reconstitution. BET inhibitors, BCL2 inhibitors we know can affect GVHD, and we need to be thinking cleverly about how we integrate these into the transplant pathway. So I think one of the challenges, like most myeloid disorders, is that we have a whole host of prognostic scoring systems to help us make the transplant decision. If we look back to IPSS, which was published in 2009 from over 1,000 patients with primary myelofibrosis, it's probably the easiest to apply, but is only applicable at the time of diagnosis. We then have the dynamic IPSS using the same 5 factors, and then the DIPS Plus, which added on transfusion dependency, thrombocytopenia, and bad risk cytogenetics. In clinical practice, when we look across these scores, day to day, I will use DIPS or DIPS Plus and MIP70 version 2, because that's looking at clinical, pathological, hematological features, and then using your NGS panel results for what are so-called high molecular risk mutations. And as we all know, classically in this particular model, these were ASXL1, EZH2, SRSF2, IDH1 and 2, and pathogenic mutations in U2AF1, which we know correlates strongly with the presence of anemia in myelofibrosis. In the UK, the Cambridge group, over 5 years ago, published on the Sanger model, now called Predict Blood. And it's a very handy online calculator to prognosticate across MF, PV, and ET about how long your patient will estimate to remain in chronic phase and risk of transformation to blastic phase. And then we also have the MTSS that I'll discuss in more detail, which is a transplant-specific score. So why is timing getting more complicated? We know that despite activity increasing for myelofibrosis transplants, it's still a rare disease and it's a rare indication for transplant. And we're never going to have randomized trials looking at the timing question. We have new drugs, we're looking at new endpoints, where we need data on how we sequence them prior to transplant. And I think the decision process is reflective of the heterogeneity of the disease, but also the heterogeneity of the patient. If you look at the non-transplant MBN population, there's often a discord between what we want as clinicians and what the patient actually wants, because clearly we can have a high risk, MIP70 patient, an excellent donor, a SIB, and actually that patient's in their 40s, they have a family life, they're working, and actually for us to say, let's move you into transplant, stop work for 9 months, and by the way, you have a 20% chance of dying in the first year and a 1 in 4 chance of relapse, that could be difficult, particularly for the younger group of patients. So who are we transplanting across Europe? We, on average, in the EBMT, have between 750 to 800 allografts registered for both primary and secondary myelofibrosis. Reflective of the drugs that we have, there's an increasing delay from the time of diagnosis to getting them to transplantation. We're transplanting older people, more unfit patients, and since 2019, around 10% of activity in the registry is through haploidentical transplantation. So as you know, several years ago, 2 years ago now, we updated the ELN EBMT guidance on considerations to transplantation. So there were differences from the 2015 guidance, and here we used the MIP70 version 2 and also integrated the transplant-specific score, which is the MTSS. So in brief, it's those patients on DIPS, so the easiest to apply score with intermediate to high-risk disease. If we're using MySeq PM for post-PV and post-ET myelofibrosis, again, those with intermediate to and high risk and MTSS low or intermediate. If you're looking at the intermediate risk 1 group, the more difficult group, there is consideration to transplant as long as the MTSS score is low. And we do suggest transplant up to the age of 70, but above that, and that's not our practice in my centre, but many centres do, that's an individualised team and patient choice. But that's clearly only focusing on the disease prognostic models, and we have many, many other factors that, for those of us in the room who are transplanters, will determine a successful post-transplant outcome. So actually, what data do we have? This is data from Nicholas Kroger, published in over 10 years ago, comparing transplant versus non-transplant strategies in around 450 patients. And clearly, transplantation favoured longer and more improved overall survival for those with intermediate 2 and high-risk disease. It crossed over as regards to Kaplan-Meier's for those with intermediate risk 1, and clearly non-transplant strategies favoured those with low-risk disease. And long-term survival on the Kaplan-Meier's on the right favoured those with intermediate 1, 2, and high-risk disease in CIB-MTR data. I've talked about the MTSS. I think this is a helpful score. Certainly I will consider it, but I think we need to be aware of caveats with using MTSS, even though it made it into the EBMT and ELN guidance. This is a transplant score that was derived from only over 400 patients. It was validated in a small group of patients, only 200 patients, and here they're looking at age, looking at donor type, performance status, white cell count, and non-CALR MPL driver mutation. And if you look at the bad risk mutations in myelofibrosis, the only one that made it into this model, interestingly, was ASXL1, and that's probably one of the more controversial mutations as regards being associated with an adverse prognosis in myelofibrosis. So I think I will consider the MTSS, but we need to be aware that it's derived from a very small cohort of patients. And then what about MIP70, so the molecular annotated scores? This is retrospective analysis using propensity matching from the French and German group, showing that yes, if you've got MIP70 high-risk score, they benefit from transplant, and those with intermediate risk using the MIP70 score benefit as long as the MTSS score is low or intermediate. But I think one of the things we need to be aware of is transplantation at the time of best response. We know if we allow our myelofibrosis patients to get older, there's a high chance of them never getting to transplant. We know that at diagnosis, less than 10% of patients are transplant eligible. What we don't capture in national registries or in our national and international transplantation registries is those patients who are transplant eligible at diagnosis and who never get to us in transplant clinic and actually miss their chance of a curative procedure. There's a higher chance of them getting comorbidities, and we know that both HCTCI and poor performance status are predictors of poor outcome, the higher the scores. And I think we need to be aware that the median time to have an ongoing response to the commercially available JAK inhibitors is somewhere between 3 to 4 years. And if you get disease progression, particularly clonal evolution or thrombocytopenia, happening whilst you're on a JAK inhibitor, then we know that actually many of those patients can transform and never get to transplant. If you acquire transfusion dependency, bulky splenomegaly, these are all adverse prognosticators for post-transplant outcome. So for us, I think we should be advocating for transplantation at the time of best response. So what about other factors determining outcome? Does TCI, we've seen transplant conditioning intensity index across MDS and AML. If you look at all of the myeloablative and RIC comparisons from us and EBMT, from CIBMTR and other collaborative groups, if you look at long-term overall survival, there's no difference. There's clearly trends towards less relapse with using myeloablative approaches. And if we are considering MAC for those younger patients with myelofibrosis, clearly we avoid TBI and we tend to favor busulfan and cyclophosphamide-based conditioning. So this is work that's just been published from our group in EBMT, looking at almost 2,500 myelofibrosis patients, showing that actually what we wanted to ask was, does TCI index have a role in myelofibrosis? The top line answer is yes. If you're using TCI intermediate or high regimens, it associates, as you'd expect, with lower rates of relapse, but higher risk of non-relapse mortality. But it does give you better stratification than conventional myeloablative or RIC classifications, which we know we should be refining. What about alternative conditioning regimens? At least for us in the UK and the rest of Europe, we predominantly favour fludarabine and busulfan and fludarabine and melphalan-based approaches. This is data from our group looking at treosulfan. You'll see further data coming from the EBMT, but in brief, in this relatively small cohort of patients, those who had treo-based regimens for their first conditioning had significantly better outcomes than those with higher dose busulfan and a trend towards better overall survival. What about donor selection? I think that does clearly affect decision and timing. It's much easier if you've got a MUD or a sibling transplant versus a 9 out of 10 or haplo. So I think historically we were always challenged in myelofibrosis field because the diagnosis of myelofibrosis usually excluded patients from the haploidentical trials. So this is a paper that's under review. It's the largest cohort of haploidentical patients with myelofibrosis of 260. Around 2/3 had peripheral blood, 1/3 bone marrow, a stem cell source. And predominantly these patients were conditioned with flu-bu and thiotepa at either MAC or RIC dosages, and predominantly using PT-Cy. I think top-line message with a median overall survival of about 60 months is encouraging. There was no difference in overall survival, relapse incidence, progression-free survival using bone marrow versus peripheral blood-derived stem cells. And clearly, and we've shown this before, if you're using peripheral blood as your haplo stem cell source, using a higher dose associated with much quicker engraftment as you would expect, but no other differences as regards GVHD rates. So do we actually, when we have a choice of donors in the less matched setting, do we have other data to inform the decision? So this is data from Tanya Jane, who published on 121 haplo patients versus MUDs, mismatched unrelated donors and sibling donors. And this was nice data because what she showed was actually clearly in the first 100 days, outcomes favoured use of a matched sibling donor, and that was mostly due to less graft failure, less non-relapse mortality. But actually in the longer term, there was no difference between donor type as regards overall survival, disease-free survival, or relapse incidence. I think our data from EBMT is slightly different. You can see we had much larger numbers to do the comparisons, and we showed very comparable results for matched sibling donors and matched unrelated donors with no detectable differences, so I think that's encouraging. We still saw signals for worse overall survival and non-relapse mortality for haplo and mismatched MUDs. But interestingly, why were the mismatched MUDs dying? Clearly that's grade 2 to 4 GVHD, extensive chronic GVHD and non-relapse mortality, but those differences actually disappeared with that cohort of patients that we analysed who had received PT-Cy in the 9 out of 10 donor setting. What about other aspects for the conditioning? I think there is a move for many transplant centres to move for PT-Cy across all donor types. I think in myelofibrosis the question is still there for clearly the sibling donors and the matched unrelated donors. This is a comparison you'll see published in the American Journal of Hematology recently. And the top line message here is that PT-Cy across the group versus ATG associated with less extensive chronic GVHD and improved 4-year GVHD-free, relapse-free survival. But the challenge for PT-Cy in this myelofibrosis group is clearly what we all know with the use of PT-Cy, longer time to engraftment, higher risk of graft failure, and potentially more infectious complications. So coming back to the title of my talk, which was optimizing timing, I think I've shown you about the prognostic models we have, the up-to-date data from predominantly registry-based studies. And what we wanted to do within EBMT, when we have such a large population of patients, internationally based, was to look at machine learning. And this is a paper we published in Blood earlier this year, looking at clinical pathological features of over 5,000 myelofibrosis patients, and looking, can we compare conventional Cox regression analysis and a CIBMTR score to improve prognostication for that patient sitting opposite you in clinic. So we compared random survival forest models alongside traditional Cox regression. Outputs were overall survival and non-relapse mortality. And the machine learning model in predicting non-relapse mortality and overall survival as the endpoints was compared to the Cox-derived model and also the CIBMTR score. So just in brief, the CIBMTR score looks at 3 simple factors: donor type, anemia, and age. And importantly, this is the first model to include haplo transplants and also the use of PTSI, which all the previous models have not done that. And this is a marked improvement in being able to inform your patient as regards their estimated survival post-transplant. And this score is able to identify a much larger group of patients who unfortunately will have a more adverse outcome post-transplant. So if you're sitting on the fence about whether or not you're going to bring that patient into transplant, and you apply this simple online calculator, you can estimate the post-transplant outcomes. And we encourage you to use the score. And this is an example of a case of a 65-year-old with primary myelofibrosis, normal karyotype, JAK2, ASXL1, and his donor availability is a 9/10, or a haplo, and here you can see very high-risk output if you're using the 9/10. What about ruxolitinib? This is data from the EBMT by Nicholas Kroger, and I do advocate strongly that when you have your intermediate 2 or high-risk patient on a JAK inhibitor, and they're doing well, move them directly into transplant. That can be difficult. They feel well, they don't want to undergo a procedure with high morbidity and mortality, but actually you will get better results. And we showed this from over 500 patients who were JAK inhibitor exposed with ruxolitinib. The group was divided into those who had a response to ruxolitinib versus those who never got a response or who had got a response and then lost the response, and we compared event-free survival. And here you can see that event-free survival was markedly improved for those patients with ongoing response to ruxolitinib. We saw a near significant trend to less relapse, and we have at least 2 global international phase 1/2 trials of looking at this question and showing that actually you're seeing better outcomes for peri-transplant use of ruxolitinib and transplantation at the time of best response. So in the last few slides, do we have any other data to look at optimizing timing? I've said at the start of my talk, we'll never get a randomized trial looking at timing. So this is a simulation of a randomized clinical trial that Nico Gagelman presented at ASH last year, looking at both primary and post-PV and post-ET myelofibrosis. They averaged the calculator over a 6-year follow-up and really wanted to look at the timing, which actually feeds back into what I've said already about when we should consider transplantation. So in brief, for those patients with intermediate 2 and high-risk DIPS on MIP70 score, you should be thinking about transplantation within the first 12 months. Clearly, delay can happen for those with MIPS intermediate for up to 2 years and 3 years for those with low and intermediate risk 1 disease. The same can be said for MySick PM. I think MySick PM is a nice score. The caveat with it is it's only from over 400 patients, and we've seen very recently published work that you can use MIP70, which was obviously only from primary myelofibrosis, but you can use that now in your post-PV and post-ET myelofibrosis population. Again, telling you about immediate transplant for those with intermediate 2 and high-risk disease. And what about TP53? I think, akin to other myeloid disorders, it's always a difficult choice if they're double hit, but you do tend with this model to get better, as you'd expect, outcomes if you transplant them quicker rather than letting them be delayed. So this is a nice publication you can see in the abstracts of ASH telling you about immediate versus delayed transplantation. TP53, I think we still need, like in every other myeloid disorder, a lot more data in the myelofibrosis field. As regards accelerated phase, our practice is to get them to transplant as quickly as possible. Interestingly, if you look at accelerated phase versus chronic phase, transplantation outcomes, they have similar overall survival and non-relapse mortality, but as expected, there's a much higher risk of relapse. And I think this is something that the registries need to publish further on, and you'll see more data in 2026. So to conclude, I think we need many more pragmatic guidance on optimizing transplantation timing for myelofibrosis. Our practice for the last 5 years has been to integrate ruxolitinib at a low dose through conditioning up until the point of engraftment, and then we stop. We have presented from our center and other centers that it doesn't affect chimerism, it doesn't affect time to engraftment. We're not seeing signals for higher infectious complications. And with momelotinib, I've transplanted about 10 patients off the back of momelotinib, and I simply half the momelotinib to 100 milligrams and carry that through until the time of transplantation. I think we need to think better about integrating the other new drugs, and most importantly, if we're thinking about that fact that 1 in 4 of our patients will relapse, we need to think about maintenance strategies. I think I've mentioned the CAR. I don't have time to go into it in detail, but this is very nice work that Alex Rampotis in our group has shown with the team in Oxford, targeting all types of mutant CALR with a CAR T-cell that they developed in Martin Poulet's lab. We're currently setting up a phase 1 trial of 12 patients, so we want to watch that spot with interest. And I think take-home messages: get the right myelofibrosis patient into the transplant clinic at the right time, use the correct score. For us, that's both clinical scores and molecularly annotated scores. And I would encourage you to use the online EBMT calculator. And I think we have many, many gaps in our knowledge that hopefully, if we're talking about this in the next 10 years, some of those will be answered. I'd like to thank you for your attention. I'd like to thank all my group within the EBMT and UCL. And finally, I'd like to invite everyone to Madrid at the end of March 26 for the EBMT. And thank you so much for your attention.